the community wellness centers for elite health. So wherever there is an elite health, you will find a community center that's open to the public, where we do presentations like the one you're going to hear today. And we also offer, for those employees getting ready to retire, a Medicare 101 classes that we can also bring to you here. I want to thank Baptist Health for inviting us and being very specific on who they want to hear today. And with that, I give you Dr.
Thank you, and good morning, everybody.
Good morning.
And thank you for allowing me to be here today. So, this is going to be an interactive lecture. I got to get through some of my stuff. I left you some of these things for you to take home, which I'll keep referring back to. And there's many names that I used to give this lecture. Did grandma give you heart disease? Why do healthy people develop heart disease? And I will tell you that a lot of people come to see me really for the wrong reason. They come in for chest pain, they come in for palpitations, they come in for shortness of breath. And really, within a short amount of time, I know if it's real or not. That doesn't mean we don't put you through diagnostic tests. But a lot of people come for the wrong reason, because when I see them and I evaluate them, we notice that they're here, in my mind, for cardiac risk prevention. And what do I mean by that? So, why do healthy people develop heart disease? Why do marathon runners develop heart disease? If you have blood pressure and your cholesterol is perfect, why do those people develop heart disease? So, thank God you're here and you're not in the CPR class, which we're going to try to avoid the CPR class. And because if you listen to what I have to say, it's going to open your eyes. It's going to make you look at things differently, the way I look at things. I'll preface that by saying that I've been in the community since 1995. I've been a physician practicing cardiology since 1991. And one of my mentors, who taught me a lot about this, was a gentleman named Arthur Agustin. So if any of you know Arthur Agustin, he is the South Beach Diet Doctor. But he didn't become famous from the South Beach Diet Doctor. He became famous in something called the Agustin-Janowitz score, which is what we're going to talk about today, which is heart scanning or calcium scoring. It's one of the things we're going to talk about today. He also taught me a lot about prevention. That, why are we sending all these people for surgery? Bypasses, angioplasties. How do we prevent this from happening? Those are not cures, okay? And we're going to go over that as well. So with that being said, what we're going to do, I'm going to bring you through a little journey. And so you can follow me. And if you have a question, stop. Yes. Let me put back my earpiece. Did you hear me or no? So why do healthy people develop heart disease? So let's talk about what are the major risk factors for heart disease. High blood pressure, high cholesterol, smoking, and a family history. Diabetes is considered a risk equivalent for heart disease, which means it doesn't matter if you have heart disease the way I approach you, as if you did, okay? Because diabetes is a risk equivalent. The more risk factors you have, the more likely it is you'll develop heart disease. So, out of the 4 risk factors there, the most easily modifiable is smoking. You stop smoking, that risk factor goes away. For those who like to cut down, that's great, but it only takes 1 cigarette a day to maintain that risk for heart disease. The more you smoke, lung cancer. So smoking is easy, and plus there's great medicines on the market today to help you stop smoking, such as Chantix. I've been around for a long time. We get people to stop smoking within 1 week. So if you're a smoker, think about Chantix. Psychological, physical part about it. The physical part you would think is the hard thing to stop. That's the easy part. It's a psychological thing. High cholesterol, easily controlled today. If you use statin non-believers, there's other medications out there today. Blood pressure, the typical person requires 2 to 2.5 medications per day to control blood pressure. If you've been reading the papers lately, the new guidelines have even lowered blood pressure parameters more. Why? Because we realize that having 140s is not really good enough. People are still having strokes and heart attacks. The family history, unfortunately, you can't change. But that's the number one thing that I look at when I see somebody, is what is the family history. So if mom or dad have premature heart disease, my ears pop up. If your grandparents from either one of them had heart disease, even worse. So for the people that think about, colon cancer, breast cancer, these are all genetically linked diseases, prostate cancer. But when we think about heart disease, it works in the same way. It's a genetic disease. And if you think about it, we're so consumed in this country about doing colon prevention, breast, mammograms, and these are all great. But what do we really do to prevent heart disease? It's the number one killer of both men and women in the United States. If you added up 2 through 10, which adds, you add up all the cancers, it doesn't equal heart disease. But yet, what do we do to prevent it? What's in our guidelines? The answer is, there is none. Think about that. There's no guidelines for the number one killer of both men and women in the United States. So, some of us, like me, and there's not many like me, we're more the minority, and I'll explain that later, have taken it to the next level because I can't depend on saying, I'm not going to wait for you to have chest pain to do your stress test. I'm not going to wait for you to have congestive heart failure to do your chest x-ray. So you got to be proactive, not reactive. And that's what I tell my employees too. Anything situations, be proactive, not reactive. So what's a typical workup that you're going to get 99 out of 100 times when you see the cardiologist because you're going there for chest pain? You're going to start with a stress test. There's many different types of stress tests. But remember, the stress test is, and I'm going to show you this again, the stress test is only good if it's positive. It's only good if it's positive, which means that you have to have a blockage that's significant to cause you to have symptoms or EKG changes. Those type of blockages only cause heart attacks 25% of the times. Why? We detect them and we fix them, either by angioplasty, medications, bypass surgery. Now listen to this closely. More than 50% of heart attacks are caused by blockages not detected by stress testing. So think about that. So that's why some of you here in this room have known somebody who had a normal stress test or somebody who's in great shape and all of a sudden they go. And why is that? We'll come back to that. That's a teaser. Echocardiogram shows me the function of your heart and your valve status. So whether you have aortic stenosis, insufficiency, so you can, again, and the EKG. So the EKGs are only good when they show something. But what about when they're normal? So if you come in with a normal EKG, and this is really what happens in this world today, normal EKG, normal stress test, normal echocardiogram, see ya, call me if you need me. But is that enough? How do you determine who needs more? Any questions to this so far? Because this is important to understand. That's the normal, okay? That's what everybody does. I put these sheets in front of you. So let's talk about how we develop heart attacks and strokes. Remember, all arteries in the body behave the same way. So it doesn't matter if it's a heart attack, doesn't matter if it's a blockage in your leg, whatever. They all behave the same way. So if you look at this atherosclerosis timeline, that's how we develop blockages and how we develop atherosclerosis. So from the first decade, this would be considered normal here, okay? Normal, and as what happens, as we get older and older, third decade, fourth decade and on, what happens is that the thickness of the inner lining of the arteries gets larger, like this. Eventually, you develop cholesterol deposits, and eventually, what happens when these get big enough, they rupture. And when they're big enough and they rupture, they close off the artery. So if you were looking down a barrel, if this is your artery, you're looking down, blood going this way, we took this and we cut it in half, and that's a section. Everybody got that? Because it's important to see that. So this is what we should all look like. This is normal. But even this could show, I'm going to show you a study that even shows that could be, you could determine abnormalities in that as well. So what causes this? The risk factors we spoke about, and what makes them continue to get worse and worse is when we don't modify the risk factors. So for the people who come in and tell me, oh, my cholesterol is great, I'm on medicine, my blood pressure is perfect, I'm running 3 miles a day, but I'm still smoking, all bets are off. Because you're still going to continue to get to that level. So how do we help you identify who's at risk and what else can we do outside of the normal? Some of them are covered by insurance, some of them are not covered by insurance, but we won't even talk about that now because nothing is cost prohibitive. So the first test we do is called an endopat. We take a blood pressure cuff and we occlude the circulation in your arm, and we do that for about 5 or 10 minutes. After that, we let the blood come back in. Normal arteries expand and contract. They're elastic. Arteries that are diseased lose their compliance or their elasticity. So the first stage of cardiovascular disease is called endothelial dysfunction, and that's when the artery pretty much looks normal. But these are warning signs. So these are telling me, so by the way, I want you to know, whatever I tell you, these are prevention things. It doesn't mean if you have any of these things, you're going to die, you're going to have a heart attack. And I tell a lot of patients, listen, don't lose sleep tonight because I'm just giving you information, okay? So I don't want people to have nightmares tonight and think of evil Dr. Krichmar who's told you all these bad things. I'm just opening your eyes. That's what I'm doing, okay? So the artery looks normal, and that's why I give you these to go home. So the artery looks normal, but they lose their elasticity. Why? Because maybe the blood pressure is causing stress on that artery. Maybe there's getting cholesterol deposits that are starting in here that are doing that. Stage 1. Now, by the way, I'll also tell you, you can skip stages. You can go right to stage 3, back to stage. It doesn't matter because why do people develop disease in one artery and not the others? So we don't know that answer. So therefore, these are just screening tests that helps us identify. So the first one's an endopat. The second one is a carotid intermedial thickness exam. So let's make believe this is your carotid artery, and this one is a representation of your coronary artery, but I already told you all arteries behave the same way. Again, this one. This is a cross section. So if I cut the artery in half, you're looking down the barrel, so blood goes this way, and this one is I turned it that way and I cut it in half. So what does the CIMT do? So if you look at the second stage of how we develop endothelial dysfunction, it's thickening. So when I have those people who come in with their LDL cholesterol of 130 and 140, and they have at least one other risk factor, which puts you at moderate risk, you need to be treated. And the guidelines say your LDL should be below 100. Now, whether we put you on diet or whatever, that determines it's a case-by-case basis. So how do I differentiate those people? One would be the endopat. But what happens if I told you your LDL is 145 and you've absolutely refused to be on any kind of Medicare? I'm going to do it. Don't worry, I'm going to lower it down. So if I did a test and I measured the inner lining of your carotid wall, we know that the thicker the inner lining of your carotid wall, the more at risk you are for developing a heart attack and stroke. We age match you against other men or women your age. And if your carotid is thicker than 75% of them, then your risk is much greater than the average population. Now, we're not talking about blockage, okay? So we're not talking about this. We're talking about this, thickening, and it's measured in millimeters, and it's very reproducible. So once I have that thickening, then I can go from year to year which way you're moving. Are you getting better or are you getting worse? So for that person who has that LDL with that bad cholesterol of 145, and they don't want to be treated, and I do this, and I say, listen, your carotids are thicker than most people. Your endopats is abnormal. Do you want to be treated or not? I don't insist. I give you the facts. Here, we make these decisions together, okay? Well, if you don't want to be treated, then perhaps maybe the psychiatrist is the next way to go, but otherwise, I'm just throwing fuel on the fire, okay? I'm just showing you what you're up against and we're up against. Still doesn't mean everybody needs to be treated. It's age dependent. It's how you are. What other risk factors do you have? So this is test number 2. Now, here's the oxymoron, or here's the unusual thing about this test. This test is in my guidelines, and all our guidelines and how we risk assess people. It's recommended by the American College of Cardiology. It's recommended by the American Heart Association, but yet it's not covered by insurance. So if you're asking me, do I go by the insurance guidelines? The answer is no. I'll recommend the test. Again, it's not cost prohibitive, and we do it once a year. So that's just showing you, again, I'm going to come back to that. So let's talk about Baptist's reason why I'm here today. I happen to order a lot of these tests as well, and these are called heart scans or calcium scores. So heart scans and calcium scores determine if you have any calcification in your coronary arteries. Here's one artery here, here's one artery here, here's another artery here. And how do we get this stuff? And what does it mean? Let's go back to this guy here. So, again, for the same things that cause all of our thickening in this plaque formation, high blood pressure, high cholesterol, family history, smoking, diabetes, what happens to these guys is they continue to grow and grow. Eventually, when they're big enough, they rupture. And when they're big enough and they rupture, they close off the artery. That's how you get heart attacks. So let's talk about that person all of a sudden. So you might have, let's make believe this was 70%, 60%. So it would be covering half the artery. Everybody envision that? Okay? So that thing could be stable, 50%, 60%, but yet you're not treating your cholesterol, you're smoking, and all of a sudden, like a pimple, it opens up. And when it opens up, it occludes the whole artery. That's how we get heart attacks. It's very simple. We know how they happen. So it's the destabilization of that plaque which ruptures, which causes a heart attack. Fortunately or unfortunately, most people who have this plaque rupture feel nothing. And the way that artery heals itself is by calcifying. So the only way to get coronary calcification is by having a ruptured plaque that heals. And we can detect that in the CAT scanner. You get a score based on your age again. 0 is normal, 400 or greater is considered significant. But, there's a but. The younger you are, the more significant that score becomes. So I told you 400 is greater. Okay, and by the way, I have people who have scores of 2,000, 3,000. This is not indicative, this test is not indicative of blockage. It tells me nothing about blockage. So when I see readers who read these tests and say there is a significant blockage in the left anterior descending artery, it's a bunch of hogwash. There's no way you could determine that, okay? This is simply another risk stratification test. And we know the higher that number, the more at risk you are, but it doesn't mean you have blockage. Because remember, as I told you before, you have to have a blockage that's 75% or greater to be a flow-limiting lesion that's going to cause you to have symptoms or an abnormal stress test. Anything below that, you don't have symptoms. And even if you're catheterized, if you have a cardiac catheterization or an angiogram and you have a 70% blockage, they're not going to do anything about it. They're going to leave it alone. So just because they see it doesn't mean they're going to fix it. So it has to be significant, and they can measure that through pressure. So on this one, on the heart scan, basically, again, this is a test that's covered by Medicare. But I will assure you with great certainty, and Baptist can verify this, most of the private insurance companies do not cover this. It's not cost prohibitive. And so when I put all this together, now I have your EndoPet, now I have your CIMT, and now I have your heart scan. If I put them all together, they become, now I have an arsenal of that I can bring back to you. And when I was going back before, so let's make believe, and who do I recommend this for? So somebody who's at the age of 50 for a male, 55 for a female, unless you have premature heart disease. So just like in colonoscopy, if one of your parents had premature colon cancer, we typically move you up 10 years prior to that event. So if they had it at 45, you're getting a colonoscopy at 35. So if they had it at 50, you're going to get it at 40. Same thing with here. So if I find somebody that had premature heart disease, which again is a very poor indicator of future events, that's what make me move this test up. So let's make believe you're a female that's 50 years old. and you have premature family history of heart disease, and you have a score of 3. So what a lot of physicians get fooled about here is that, oh, it's a low score, don't worry about it. But if you have that score at 3 at 50, you're probably above the 80th percentile, which means you have more calcium than most women your age. So it becomes significant. It doesn't tell me you're at risk for having a heart attack tomorrow. It tells me how aggressive you need to be treated. Because if you have it at 3, what should you have at 50 years old? 0. So if you have anything but 0, it's very significant. So you can't get hooked up on just a score, because I told you, but again, let's talk about insurance. So when we do stress testing, there's many different types of stress testing we could do, whether it be plain stress test, stress echo, nuclear stress test. So if I think somebody really needs a nuclear stress test, and I have to go through the insurance to get it approved. Now, I'm not saying I think that nuclear stress testing in the past has been overutilized, but there's certain people that really need it. So one of the ways that you get it approved, if you have a heart scan of 400 or above, or you have a high heart scan. So they look at this as an example of how aggressive we need to be, but yet they don't want to pay for it. Figure it out. I mean, I'm not here to figure out the insurance industry, so forget about that. This is Heart Month, and this is why I'm here. So Baptist really does a really nice job of this. They're all over the place, just like McDonald's, so you can find them anywhere. And they do a nice job, and so it's Heart Month. It's a discounted rate of $50. Typically, it's $100, and covered by Medicare. Is it covered by Medicare, or every day I hear something different? Baptist?
Not covered by Medicare.
But it was, and now it's not. There you go. Okay, they don't. I guess the government doesn't think this is an important enough test to do. So, 3 studies that I just showed you already. Let's take it a step further. Are you confused, or you got it? Clear? Crystal? This is what I spend my time in when I see patients. Not talking about your chest pain, which is not real. This is what we talk about. It's a little confusing now. So you're all used to getting your cholesterol. This is mine, right? I wasn't. So you're used to getting your cholesterol, and you get a total cholesterol, an HDL, a VLDL, which is triglycerides. Those are your typical patterns that you see. HDL, LDL, triglycerides, total cholesterol, and a ratio which means nothing. What does it mean to me? Nothing. Because you've got to risk assess the patient. So it means to me on how I need to treat you, but what happens again? Now, I prefaced this conversation by saying, well, what do you think the marathon runner has? Do you think he has that normal cholesterol? Of course. How many of you have gone to your doctor and said, my HDL is so high, I don't need to be treated? So, how do we know who needs to be treated? Does the cholesterol give me the answer? It's your typical cholesterol that all of you are accustomed to hearing. And the answer is no. It only accounts for about half of the cholesterol abnormalities that cause heart disease. The other half, the genetic half, you have to do what's called an advanced lipid profile. So let's now really throw some curveballs in there. So when I talk about an advanced lipid profile, it tells me how you need to be treated, and if you are being treated, if you're being treated effectively. Because depending on which advanced lipid profile you have, there's more than one LDL, there's more than one HDL. We're looking at inflammatory markers, C-reactive protein, LP(a). We're looking at the size of the particle as well. So when you're talking about your cholesterols, what you're accustomed to knowing, you're talking about a percentile. When you break it down in something called an advanced lipid profile, not only do you look at the percentile, you look at the amount of particles you have, the amount of numbers from 1,000, whatever. So if your percentile is good, but yet your particle numbers are too high. That's another thing that we look at. So it gets a little confusing because there's different methodologies on how we measure these things. So the best thing to do is take a little piece of everything, use what's best, and make it and use them all. And the last thing we do is look at your size of your particles. So, and I think that's the most important. So here's just something showing you something of the particle numbers. Here's your risk factors, and here's what you guys are accustomed to looking at. So on this particular example, I know you can't read it, the cholesterol is 129. You can't read what that LDL is, but it's below. The HDL is low, triglycerides are high. Just to let you know, when you see low HDL, which is your good cholesterol, and high triglycerides, that's a marker for diabetes. It's pre-diabetes or diabetes. So that's when I see that. By the way, let me know on my time when I need to cut it short because I just don't know. At least I don't have my watch. So that's one thing. So when we treat cholesterol, the first thing we treat is the LDL. So for you guys who think your HDLs are so high and your LDL is high as well, you still go by the LDL. First goal of treatment. The HDL we want as high as possible. And this is saying, just like in all of them today, 40. That's your reference range. So the question becomes, do you think 40 is good enough? This is telling you, like every other lab, 40 is the number. Do you think it's good? First of all, how do you get 40? Does anybody have a crack at it? No? It's the average HDL of the United States. So if you want to be average and still have the number one killer that's killing you, by all means do it. So therefore, again, there's a lot of fallacies on the way we look at people. So I want those HDLs as high as possible, and there's ways to do it. So for every 1 point increase in HDL, there's a 2% decrease in mortality. So if you're at 39, I put you up to 50, I've lowered your mortality about 20% just by raising your HDL after I treat your LDL. Another one is something called Lp(a). Well, this is the one that gets the marathon runners. Lipoprotein (a), or Lp(a), is an extra protein that attaches to the LDL particle or the bad particle and makes it much more highly atherogenic, or much more likely to cause heart disease. In fact, like 300 times more. It's not affected by diet, it's not affected by exercise, and it's not affected by statins. One of your parents gave it to you. 50% of your offspring will have it, and 50% of your siblings will have it if you have it, because it's genetic. So when we see that, it just tells us how you need to be treated. I could lower it, by the way, but I have no proof that it's going to do anything. But this is like the silent one. This is the one that gets the marathon runners, because they have Lp(a), or the person that you treat with angioplasty, and they keep coming back for more, because this is not being addressed. So when I see this, it's important to me to make sure that all your cholesterol parameters are perfect, okay? Again, not to scare you, but it's there, all right? So now let's look at the last thing, which I think is very important. This is a graph of the size of your particles. So if you see in this one here, let's just start from the middle. This says LDL 1 and 2, LDL 3, and LDL 4. As the LDLs are traveling through the bloodstream, they're always trying to get through this lining and lay down plaque. Think about a mosquito net or a fish net. The smaller the particle, or the smaller the fish, mosquito, the easier it is to get through that lining, to lay down plaque. So we want to see nice, large, fluffy particles. So even if your LDLs could be at 70, which is great, but they're coming, oops, sorry about that. They're coming over here, which is LDL 3 and 4. These are the large guys, and these are the guys you prefer. So when I look at this graph, and even if your LDL is in goal, it's telling me the particles are small and you're still at risk. 50% of the people that have heart disease have small LDL particles. So how do we? So if you wanted to see this graph, we want to shift it here. So we want to see the graph peak here and then come down. These are the smallest guys. So if that graph, even if it hits the green, but it's coming up here, that's really bad. So this graph shift to the left. This is triglycerides. What this means here, a little bit too high, and we know that from the triglycerides being there. So the last one is your HDLs. So the wine drinkers is HDL, what's called 2B, HDL 2A, 3. This is where the wine drinkers go. So this must be a wine drinker here. Doesn't mean it's totally bad, okay? Because when you raise your HDL, HDLs are good, but if you're going to get HDLs, these are the guys, HDL 2B, are the ones that protect you the most. So you want to see this graph come up here and then come down. So if I had to look at this whole graph, we want everything to shift to the left. We want this one to shift to the left, this to shift to the left and go down. So now I'm looking at percentiles, I'm looking at particle numbers, and I'm looking at sizes. So here, if you look at particle numbers, they see the large bore HDL2B, it's in red. This is the HDL2B, it's too low, okay? How do we correct that? Well, if there was no medicines available, diet and exercise. Weight loss and exercise makes your particles bigger and shifts them to the left. Statins don't do this. Okay, so statins lower your numbers, but they're not going to change particle size. And the other medicine that's an old, long-time medicine, which I love, not a medicine, a vitamin, is niacin, vitamin B3. So niacin, and it's dose dependent. The more you have, the better results you'll get. Will make your particles larger, raise your HDLs, lower your triglycerides, lower your LDLs, and actually lowers LP-Lil-A as well, that bad one, but doesn't mean you're going to get benefit, like I said. But the other stuff you get benefit from. So, so niacin I use a lot in my practice. A little confusing, or you got it? Okay. So what about bypass and stents? What about all this stuff? Does it cure your disease? And we want to take a crack at it?
No.
Why? It's a fix. So here's my liquid Drano comparison, okay? So if you come to my office and you've had an event and you come in heavy and you come in with diabetes uncontrolled, watch out, because you may not come back again after I speak to you. Because what leads you up to getting to this point, okay, we don't want to get to this point because this is why we do all this prevention stuff. But if you have to, and by the way, 10% of the people, no matter what we do, this is going to happen. We can't control it. But if you get to this point, some people think they get to that point, they're 240 pounds 3 years ago, now they come in, they're still 240 pounds, they feel great, that's wonderful. There's only one problem. They didn't fix you, they didn't cure you. They fixed your blockage. So think about being at the sink and throwing all your crap down the sink, you clog up the sink. How do you fix the sink? We pour liquid Drano. This is liquid Drano. We open the sink. But what happens if you keep throwing stuff down there again? You get clogged. Same thing here. So it's about lifestyle modification is how we prevent it. So no matter what all I can do with medicines and everything, if you don't change who you are, what got you to be to this point, all bets are off. It's going to happen again, especially in diabetics. It's just a matter of time. So what's my common denominator for everything? One of the main things is your weight. As a nation today, we have an epidemic of obesity. Over 30% of our population is obese. Almost 70% of our population is overweight. 1 out of every 3 kids today, born today, will be a diabetic. When I was growing up, and some of the people in this room, we were outside playing. There was no computers, there was no cell phones. It was just a different world. And I can't blame it all on that. But, you know, the portions that we get here, it's, you know, and I struggle myself. But I maintain, I gotta practice what I preach. So in my mind, you can't practice in this world to have I hate to say it, but if you have a heavy cardiologist tell you need to lose weight, what kind of example is he setting? You know, or the endocrinologist who comes in eating a Dunkin' Donut, what is he saying to you? So I think that you really have to practice, and we do that at Elite Health. So we are very keen. The first thing I look at when anybody comes into my office is your weight. That's the first thing I'm going to look at because there's no way around it. It also causes sleep apnea. It's a multitude of things. And like I said, it's an epidemic. The good thing is there are great programs out there. There's about 4 medicines today that are approved by the FDA for long-term use, 5 years or longer. Even for the people who go for the sleeve procedures or gastric bypass, it's the same thing as liquid Drano. You could do that and you're going to lose all your weight. But guess what? You'll start eating through it and you're going to gain it back again. It's called lifestyle modification. If you don't know how to change your lifestyle, you're going to fail. We have other different things that we do in the office. Plaque X chelation. Chelation is now a new buzz. It's been around for 50 or 60 years. It's for people, I do this for people who are at higher risk, have calcium scores that are high, or maybe had a procedure. It's been around for 50 or 60 years for people who didn't want bypass, people who didn't want angioplasty. They were doing chelation as an alternative treatment. It's still considered alternative. Mount Sinai Medical Center did a major study 3 years ago, sponsored by the National Institute of Health, that showed for people who have high heavy metals in their body, who underwent 40 rounds of IV chelation, had a 40% reduction of having a heart attack in the future. So that's why we offer it. It's not covered by anything. Repatha is one of the new drugs. There's 2 of them on the market that are not statins. I think, by the way, statin myalgia or statin muscle aches is very, very overrated. There's many ways I try to accomplish that with patients, whether giving it once a week, twice a week, trying to work them up, making sure you're taking coenzyme Q10, and there's reasons for that. But some people are definitely intolerant to statins. These are injectables. They're excellent. They work very, very well, and they're very expensive. So with that being said, just quickly about Elite Health. Here's where we are. And we're growing. We're just getting started, unfortunately for me. So we're also opening up. Our new office is going to be in North Bay Village. I would encourage you to go online, look at our website, take a tour through our offices. I think it's going to be nothing like you've seen in the past. They're modern. They're baby boomer friendly. They're technologically savvy. Our customer service is second to none. But you can just see that when you come in. We're going to be opening up probably in Fort Myers, Tampa, and Manatee County as well. So I'll shut up now, and I'll wait for questions. Don't be shy. Yes?
And again, this is probably false, but I've heard that once your arteries start to thicken or when you start to build up plaque, that there's no way to reverse that. That the only way is by bypass.
No. And let me tell you why. So if you look at this, and this is why I gave this to you guys, and thank you for making copies of these. When we measure that CIMT, the carotid thickness test, or the endopat, one of the things I told you is that we measure it every year because it can go either way, okay? Before you get to plaque rupture, all this is reversible. It may take 5 or 10 years, but as long as you're living the right lifestyle, that's what the goal is. So it's identifying those people. But it is reversible. That's why, if it wasn't, then, if you're stuck at that one level, then why would we use statins or why would we use things to modify your risks? So it's clearly reversible. So whoever told you that is not correct. Other questions? Yes?
Why do statins raise your liver enzymes?
So not all statins raise your liver enzymes. So let's just talk, very simple. And that's why I mentioned coenzyme Q10. There's about 6 or 7 statins on the market. 2 types of statins. They're either hydrophilic, they like water, or they're lipophilic, they like fat. So the statins that like fat easily pass through the membranes into the liver and cause inflammation. The ones that like water don't get through as easy. Even with that being said, it's okay to have liver enzyme elevation, because now whatever we do in medicine, there's always a risk-benefit ratio. What's your risk of taking the drug versus your risk of not taking the drug and having a heart attack or a stroke, okay? So we allow the liver enzymes to go up to 3 times the normal if you should raise your liver enzymes. But I will tell you, you know what the number one cause of cirrhosis is? It's not alcoholic. It's people that have fatty livers secondary to high cholesterol. So when you see those liver enzymes elevated right from the beginning, the first thing I'm doing is putting them on statins, where other people would be afraid to do that. So you got to monitor people. You got to be on top of your patients. The new guidelines say that once you're on a statin, we used to measure every 3 months. The new guidelines say maybe once a year. I still do it twice a year. Once I know you're stable and your liver enzymes don't go up, but I will tell you in my years of practice, there are maybe a handful, 2 handfuls, people I had to stop because of liver enzymes, okay? Any other questions? Come on, there's more. I gave you guys so much stuff.
You talked about premature heart disease and
Yes.
being predisposed by your parents. What age is premature?
So for any female that develops heart disease before the age of 65, male before the age of 55 is considered premature. So, but if you have premature heart disease in your family, more of aggressive workup for you. But if your parents still had heart disease at 75, you still get the same workup because they have heart disease, so they got the gene. So a lot of people say, I get this all the time, well, he smoked 3 packs a day and, he was a drinker, whatever the case may be. The bottom line is you have a gene. It's how you express the gene is how you get disease. Think of the light switch as being the gene. That's your heart disease gene. The light's off. Well, if you smoke and you have high cholesterol and you have high blood pressure that's not controlled, just turn on the light. So it's there because it's genetically inherited. Now, some people don't. I mean, it's not all the case, but think about just having the gene. So if both of your parents had it, then you got it on both sides. So again, it's when a lot of patients come in, oh, my dad died at 83 of this. But they fail to tell you, and I keep going over my MAs with this, and I think we got it down, is that I will still go in and say, well, did they ever have heart disease? No. But he had an angioplasty. Oh, the angioplasty. Okay, so that means they had heart disease. So he never had a heart attack, but he had angioplasty. So again, it's sometimes we got to be a dentist and we got to pull this information out. So, but that would be that answer to that. Any other questions? Yes.
If someone did have both parents that had it, should they maybe do it sooner?
So, to me, risk stratification starts as soon as I see you in the office. You could be if I have somebody who's 18 years old and has a cholesterol 400, does that mean they shouldn't be treated? So the answer becomes is that there's no age to start. Maybe based on your age, you may not need all the testing that we're talking about, but certainly if somebody comes in who's young and has a strong family history, and when you do the blood work and you check their blood pressure, so if their blood pressure's okay, their cholesterol's okay, and everything's okay, I'm not going to put them through these things even with a family history. I got to look for things to do things. So therefore, if you come in and you're 25 years old and you have a high cholesterol and a strong family history, I'm probably going to recommend a carotid thickness test. Probably not going to, sorry Baptist, I'm not going to recommend a calcium score because you're too young and it is radiation. There's no cookbook here. Everybody's treated as an individual and you got to put all the pieces. What I'm doing is I'm gathering, you're a jigsaw puzzle. All I do is gather pieces, okay? I'm uncovering rocks, I'm looking for things, then we put it all together and we form a game plan, okay? Because without those pieces, without uncovering those rocks, we're shooting blind, okay? So the answer is, it's individualized. But everybody needs risk stratification, and everybody needs to exercise and control their weight. Questions? Yes?
How much does that affect your health functions when you have?
Calcium scores are, I do them once as a screen at 50, 55, if it's indicated. If it's 0 score, perhaps I may do it in 5 years or more. If they have a score, I don't think it should be done before more than 3 years because it's not going to really change. Once I get my information, it's not going to change me whether your score is going up or down at that point. So I don't think it should be done routinely. There's also great tests today called CTA of the coronary arteries, CAT scan angiography of the coronary arteries, which are the same thing as having a cardiac catheterization, which is cardiac catheterization is when they, either through your arm or your groin, they thread up a catheter and they inject dye to look for blockages. CTA, or CAT scan angiography, through an IV, which is really like a minute test once they get started, really gives you a nice, clear-cut picture. The technology today and the scanners today are great, but who do we do that on? If somebody has a positive stress test or somebody who's having chest pain despite everything, and I don't think they're real, instead of putting them through a cardiac catheterization, perhaps you put them through a CAT scan angiography. Other questions? I'm here. Take advantage of it. This is free information right now.
What's actually the definition of heart disease? Does the artery have to be blocked a certain percentage?
No, I don't think so. I think if you have... I think heart disease is anything that's not normal. So that's heart disease. Should be there. So don't get fooled for people who've had cardiac catheterizations, or your parents have had cardiac catheterizations, and they get this term NOD, non-obstructive disease, or nothing significant. Music to my ears. Why? Because I know they need to be treated. They need risk factor. The whole point is making sure that doesn't turn into that, to that 60 or 70% that ruptures. So this is heart disease. It may be minimal heart disease. It may be early heart disease. But any artery that doesn't look like this is heart disease, or arterial disease, or brain disease, or leg disease. It's all the same. Yes? AFib. Totally different animal. So AFib is just another condition where the heart beats irregularly. Typically people who come in for AFib, and the way they're treated, and there's very sophisticated techniques today, still get this as a, when somebody has atrial fibrillation, you got to make sure they don't have coronary artery disease. AFib is where typically you have a one-to-one, the atrium contract, the ventricles contract, the atrium contract, the ventricle contracts. For a multitude of reasons, thyroid disease, alcohol, or we don't know, aging, the atrium start beating at 200 to 300 beats a minute, and the ventricles beat variable. Not, if it was 200 to 300, you wouldn't be alive. So the major risk factor for atrial fibrillation is strokes. And there is classifications that we use to risk stratify you to say, what is your stroke? It's an algorithm that it's online, and based on your risk stratification is those people who need to be on blood thinners or not. So, but still, anybody who comes in atrial fibrillation should have a workup done. Questions? Yes? It stabilizes it. Again, think about this plaque that can continue to, if you don't treat, you just move to the right. Your goal is to stop the progression, stabilize the plaque, prevent the plaque from that pimple and rupturing. So, any modality that we use to modify your risk, when I say modify the risk, means it's stopping the progression. And also keep in mind, in my practice, just because you put on a statin or you put on blood pressure medicine doesn't mean you're going to stay on them. Okay, I've seen many people reverse, and I'm proud of that once we get them to lose their weight and change their lifestyle, we pull it back. But a lot of people's attitude, which is incorrect in my mind, is I'm going to lose my weight first, and then and if I can't do it, I'll come back in 4 months and we'll see what we do. And for me, why wait and lose 4 months of treatment? Go lose your weight, and when you come back, if your cholesterol's too low because you lost your weight, then I'll take off your medication. Because the truth is, sorry people, that 99.9999% of the people who tell me they're going to do it on their own typically don't. I mean, it's just the way it is. Because anybody can lose weight. Don't get me wrong. Losing weight is easy. It's keeping it off is key. So the yo-yos doesn't work. So, and I typically ask somebody, well, I'm gonna do it on my own. What do you do for a living? I'm an airline mechanic. So am I. I'm gonna go fix your planes right now. What do I know about being an airline mechanic? Nothing. What do you know about losing weight? Nothing. But yet you're going to do it on your own. That doesn't mean you can't. I mean, you could follow books, you can do things. I mean, there's great programs out there. We have our program, but Weight Watchers, I don't care. You know, the whole thing for me is I don't care what you do. Do something. Be held accountable. So therefore, you're paying money, whatever you're doing, you're held accountable, and you can answer to somebody. If you do it on your own, because the problem is you're going to lose that 20 pounds. And then you're going to get here, and you're not going to know what to do anymore. You're going to hit the wall. I can't lose any more weight. I don't know what to do. So guess what you start doing? You start eating again. It doesn't work.
So I know you're going to talk about the heart disease, but is the elite health, is it the whole body, or is it just focused on the coronary?
Elite health is really primary care. I'm the only cardiologist in my office, but I teach the people, my doctors, my nurse practitioners who come into Elite Health, everything I spoke about today, they are trained to do so. Because in my mind, you don't have to be a cardiologist to do this, nor do you have to be an endocrinologist to start insulin. So therefore, it's your primary care doctor who's well-rounded and who's in Elite Health is well-rounded, because we won't hire them if they're not, and I'll teach them if they need what they need to learn. But everybody got to be able to do this. So I'm the cardiologist, and I also do some primary care, but I'm not looking to do primary care, but I do evaluations. If I evaluate you, then I'll give you one of our primary care. But I think that, again, I would urge any of you just to please come by the office unannounced and see for yourself the Elite Health experience. I'm not here to talk about Elite Health, I'm talking about here, but it's really a wonderful experience, and everybody does this. So when you come into my primary care doctors, they know what to order, they know what to do, unlike your other, not saying anything bad about any of your doctors, don't get me wrong, but you got to be trained to do this, just like I was trained to do it, okay? But most cardiologists don't do this. So it's individualized. That's why we're growing. Other questions? I didn't hear anything in my earpiece, by the way. So, are you guys sleeping out there? I want to thank you all for coming. If any of you need my cards, Jennifer, my assistant, has them. And thank you so much, and I hope it was good for you. Thank you.